You can solve most of the problems by doing a couple simple things. There's a guy at the company I work for who has all these special orthopedic tests, knows the names, knows the tension. But honestly, it's not going to help the vast majority of the time. The vast majority of the time, there are 4 or 5 things you can do that fixes most shoulder problems. So specifically for clinicians, we want to figure out how to get good at solving most of the problems most of the time.
My question would be, what is most of the problems with the shoulder? Because then you can say, what is the 20% that will work for 80% of the cases? But what are those cases? Most of them, I mean, there's crazy cases, right? There's crazy shoulder blade cases. But what are almost every case that walks in about in the shoulder and the glenohumeral joint? What are most of them like?
Let me phrase it more like this then for you, and then I'll take a stab at it. Does the shoulder blade need mobility or stability?
It depends. I do think it most likely, most of the time, needs more mobility, in my opinion.
Okay.
I don't know if you were actually going to agree with me on that. I mean, that thing's got to move. And a lot of it can be control issues. Sure. I mean, I understand that goes back to this this kinesiology or kinematics of the shoulder blade that we were talking about. But I think mobility for sure. What was your other question that tied into it?
No, just mobility or stability. What does this what are the majority of shoulder blade problems? Are they mobility problems or stability problems?
If you get those super lax people, maybe they need to have a stability issue. The people that are hypermobile, ligamentous in their whole body, you can just grab their humeral head and move it all over the place inside the glenohumeral joint. People that can reach, way too high on a backside reach test, any of the ATHLEAN stuff, the people that are super hypermobile, they might need some control and some stability. For most other people, I think it has to do a lot more with mobility and control. Gaining more of that will solve a lot more problems. But sometimes they, you say, okay, why can't they gain that mobility? And that can be a structural issue where they're running into things, or they can't inhibit things. Therefore, they can't get that mobility. But I do definitely swing to that side.
No, I think you're correct. And I mean, the other way you could phrase it would be the Dr. Spina way, which would be that would be the question, and then he makes it totally different. Mobility, yes, but the ability for let's just say like in protraction and retraction. For protraction, oftentimes the motor control in the short contracted position is poor. So shoulders, let's just stick to shoulder blades are very good in the mid ranges. But whenever you get to when those muscles are in a short and contracted position, contracting more becomes a problem. And so then we end up running into joint space problems and tweaking and torquing ligaments. Or in the protracted space, in that far out and reaching spot, you also have a problem contracting and keeping some tensile integrity through the shoulder blade. And then that's where it creates torque. So it is mobility to be able to get to either end of the spectrum. But then once you're at that end of the spectrum, protracted or retracted, do you have a good position? Are you not too hiked up or too hiked down? Can you maintain the control of your shoulder blade at those end ranges with some sort of stability? So it would be the mobility to get there, but then also the contractile strength that you have to control.
Would you agree that, I mean, we've talked about those guys a lot and we give them a lot of credit, but wouldn't you agree with this statement, which would be something like, the FRC guys are saying, okay, first we got to get you to do scapular CARs. In other words, we got to make sure you can control your scapula. And you control it well, and you control it in all those ranges, short range, end range, things that you were just hitting on. But so many times, no matter what kind of mental focus that person has, it is not up to them to recruit the right muscles to do the job based on position. So if you have somebody, let's say extremely flat T-spine with a shoulder blade that's hiked up and tipped forward and very tight pecs and everything, and you say do scapular CARs. Now, it's probably good in general for the shoulder to move it, of course. but there might be no way that it's possible for them to recruit correctly. In other words, they might be over upper trapping it for half of that CAR because they're not able to turn on certain things. So that's where the complication comes in. I don't know if you agree with that statement, that this is always been my question for them, which would be the respect for position. And I think it's easier to bypass that and just say, move it until stuff works nice, or shit works nice, as they say. Make shit work nice. Well, sometimes I don't think that always works. I don't think it always works because they're in such poor position to begin with, and the recruitment patterns are so messed up that all of a sudden you get a pec that cramps up, or you get a hamstring that freaks out. They can't even do it. I mean, over time, sure, it improves a little bit, but if you don't adjust the position, I don't know how you improve that.
So like, I'm 100% on your side, actually. I mean, I think there is this thing where, doctors are talking about, don't enable your patients and make them dependent upon you. You know what I mean? And unless you have somebody watching, like if you've ever seen some of these FRC guys, like Q people, they are like, poke, 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 here, contract right here. As you go up, now down, now tilt, now 2 degrees this way. Holy God, dude. I don't want to do that forever. Like, if that's your passion, God bless. But I don't want to have to be there constantly. And also, I don't know that if you're having to make these conscious changes, as someone's kind of tapping your rhomboid, the lower half of your rhomboid minor as you are in 45 degrees of flexion, if that actually starts to stick when you go to grab a can of beans from your cupboard or something. So I'm on your side. What do you mean? Okay, fine. It's good. It's not bad. But what I agree with you, what you mean with position. So what do you mean by position?
Well, let's say you're going to work on glenohumeral CARs, right? Like you're going to move your arm on your scapula.
Yeah.
Well, let's say the position that scapula sits in. Let's say there's an extremely pissed off pec minor that you don't really address. You have very weak, muscles that might control the inferior angle on the backside. So you don't have any opposition to the pec minor. It's just free to go crazy. And but you're doing your CARs, you're doing your rotations every day. It's good for the joint. I agree. The movement, and I'm a big fan of them, period. So just so I know, just so everybody knows. But it's great for the joint to move it. But maybe you give yourself bursitis. You can give yourself rotator cuff itis and all the other things that you can piss off, because if you're trying to spin a humeral head in a joint that doesn't allow it to, you can irritate things as well. So you can have the patient come back, and they don't always come back and say, oh yeah, my cars fixed all my problems. So actually, no, now I kind of had to stop them because my shoulder's irritated. Well, maybe they're cheating horribly on the CARs and they don't know how to do them properly, but also maybe they can't do them correctly, and that's what I'm worried about. And that's where I'm talking about, well, maybe you have to address position. And I think, like Spina would say, yeah, obviously we have to do that manual, the FR stuff that they talk about in the other courses about, let's see if we can, inhibit a pec minor first, and then maybe we can recheck but this is what I want everybody to know. You have to test and retest. So if you do your CAR and it hurts and there's impingement, well, you don't say, okay, now just go do those CARs every day and your shoulder's going to get better. It's like, how about here's a great way. Who cares what the diagnosis is? The person in front of you gets a pinch at a certain degree of doing a shoulder rotation, okay? Implement something and recheck it and see if that pinch goes away. We all know this test and retest, but I just don't think enough of us put it into practice, because that gives you the answer. That gives you, I had a case like this week, and I tried a bunch of stuff. Nothing worked. And then it was like inferior capsule stuff. I did a bunch of work on the inferior capsule. I did MOBs towards the inferior posterior capsule, like not just one thrust, but like 70 of them. And then some lacrosse ball stuff, zero pain afterwards. So I tell him, this isn't fixed at all. This will come back by the time you drive home. You know what I mean? But I can now like discern the reason why you can't move that shoulder correctly, and it's because of in this case a capsule that doesn't allow the humeral head to go posterior and inferior. So give them some homework to do, you know, and then we know admonish them that, you know, this has to be done daily. This stuff takes time to change. Check your CARs, check your rotations every day to see if it's making any difference. If you get the pain, clear it out first before you train it, stuff like that, versus just tossing whatever the algorithm says at whatever diagnosis you list, or your ICD-10, or whatever you guys have to do in the States for diagnosis.
10, yeah.
Yeah.
No, that makes a lot of sense. And like that's really specific. Again, that inferior mob stuff, and that's awesome. But I think it's good to hear those kind of things. Like you want that test and retest. Like I do for something pretty similar. A lot of my exercises are also my tests, you know, and so I'll have, like, we'll go back to Dr. Offenberger's example of the wall stretch. I'll start them very specifically and say, you start kneeling, you start with one knee down, then you put the foot up, and then you bring your torso up afterwards, and you see how high you can get and go as high as you can and stay there as long as you can. The same thing with that shoulder flexion that I gave you. And I think I talked about this test, like the more personal test, the person standing like 6 inches away from the wall, they put their hand back on the wall and they see how high they can slide their hand up the wall with their elbow pointing straight forward, right?
Yeah, for
And
those
as
that
soon
can't
as
see, your back is towards the wall.
my back is towards the wall, correct.
Yep.
The hand is, all 5 fingers are on the wall. We used to call it the itsy bitsy spider going up. And
Yeah.
don't let that elbow go out. And you want to see how high you can go up before you internally rotate and shift and lose that position. If you can't, then we have a couple stretches, and then you can go back and test. Did those stretches actually help that test? If not, then we need to adjust those stretches. They usually do. I'm the perfect clinician. That's what everybody knows. That's why they come to me. That's not true. Okay, so
I have
no.
like a serious follow-up. I know it breaks like everything we were going to talk about.
No.
But I want to know, why do 90% of clinicians see something like shoulder impingement and just prescribe rotator cuff banded exercises?